So I'm seeing a 41-year-old female presented with the complaints of headache for the past 10 days. It was sudden in onset, progressive headache, progressively worsening headache associated with giddiness for the past 10 days. She also had developed vomiting for the past 9 days. Was immediately after the intake of food, non-bilious, non-projectile, and non-bloodstained vomiting. And she also had blurring of vision for the past 1 day. There was no history of weakness of the upper and the lower limbs. There was no history of any fever. There was no history of any weight loss or loss of appetite. There was no history of any breathlessness. Past history wise, she's a known rheumatic heart disease patient who had who had a mitral stenosis, who had undergone a mitral valve replacement in 2019, was on anti-warfarin 5 mg daily for a period of 7 days. When she initially presented, general examination wise, she's conscious, oriented to time, place, and present. There was no peripheral signs of infected endocarditis. When examination wise, vitals were within normal limits. Pallor was presented. No elevation of no JVP elevation. Examination of the STEMI examination, S1, S2 present, and prosthetic click was heard in the fifth intercostal space, and there was flow murmur heard in the aortic area. Respiratory system were within normal limits. Abdomen was within normal. Examination of the central nervous system, higher mental functions were normal. Examination. It was spreading over the first into the second heart. So,
Dr. Rohit, what was the mom?
More of ejection.
Ejection systolic murmur over the aortic area, which was less than grade 3, which is why you thought that it was from.
Spelling of murmur is not
higher mental functions were within normal limits. Examination of the cranial nervous system. Examination of the fundus, there was no papilledema. External ocular movements were within normal limits. There was no history of any facial deviation. There is no history of any. There is no signs of any facial deviation. Examination of the motor system, there was no increased symptom. There was no weakness in the upper and lower limbs. Reflexes were 2+ in the bilateral upper limbs and lower limbs. The right plantar was, however, an extensor. There was no cerebral sensory system was intact. There was no cerebral signs. There were no features of any neck stiffness. So the differentials we considered were cerebrovascular accident, probable embolic and hemorrhagic etiology, and
where did we localize the lesion?
Going to the history of blurring of vision, sir, and plantars being extensor on the right side.
The examination was normal.
Yes, sir. Embolic and hemorrhagic area. And
so where did you localize that? Still doesn't.
Cortical, left cortical.
You said there was blurring of vision, right? Which part of the cortex?
Occipital and aneurysmal rupture. So we had immediately went ahead when the CT brain was done, which had shown an intraparenchymal hemorrhage surrounding with the surrounding edema involving the left parieto-occipital region, with surrounding edema. So
let's show the CT. Point out the. Either you have gotten the wrong cut or it does not show anything. There is some edema there. Can't see a bleed.
Yes, sir. Hemorrhage.
The same patient.
Yes, sir. Same. So when they were going into the investigations, the hemoglobin was low, 5.7 microcytic, hypochromic, associated with the elevated PT INR. PT was 55, INR was 4.29. With a normal ECG and the chest X-ray, with the rest of the blood parameters within normal.
ECG finding, what did the ECG show?
ECG was normal, no features of signs of atrial fibrillation were present.
What did the ECG that was normal? So sign of it?
No signs. No signs of atrial fibrillation. Chest X-ray was also normal. Echo was done to rule out any possible features of embolic origin. It had shown a mitral valve with and the rest of the normal LV function, and there were no other features. So we initially 2019 here, ma'am. Following which, so we went into, the patient had developed an acute cerebrovascular accident, left a posterior parietal hemorrhage with a supratherapeutic INR. So the patient who has been, who is a rheumatic heart disease patient, who has a prosthetic valve on anticoagulation. There was a need, the patient had developed a hemorrhage. Now there was a treatment decision to be made on which time anticoagulation needs to be done. I like to discuss on the evidence which states what time would be starting the patient on receiving anticoagulation in a patient who had developed an intracranial bleed, which we commonly see in an Indian population, like which commonly occurs in a patient who has a rheumatic heart disease with a supratherapeutic INR. So I'll be discussing the evidences on need for continuing anticoagulation in a patient who had developed an intracranial bleed, and I will be discussing the optimal time for the time we can restart a bleed, and I will be discussing whether antiplatelet therapy can be used in these patients. This is a BMJ article. It's meta-analysis involving 12 cohort studies involving receiving anticoagulation after a patient who had developed intracranial hemorrhage. They had taken 12 cohort studies from Medline, Embes, and Cochrane from the inception till February 2017. The outcome they had measured was long-term mortality, recurrent ICH bleed, and thromboembolic events. In this, they had included patients who had more than 18 years of age who had received anticoagulation at the time of ICH recurrence and survived during the hospital phase or during the acute phase or hospitalization. The oral anticoagulants they had included were vitamin K antagonists and the NOACs. So these were the 12 studies. These were the 12 studies that have been included, and the largest study being the Nason et al. Done in Denmark, which included 3,436 people. Which, who had a median follow-up period of 12 months. So, summarizing this study, they had measured three outcomes in persons who had developed ICH bleed and the need for anticoagulation. Based on the parameters, based on the long-term mortality, it has been shown that based on the 12 study, receiving anticoagulation did not significantly increase the mortality. However, there was did not significantly increase the mortality in patients. However, there was a great difference between in studies indicated by the I-square test, and it indicate that there is no significant improvement in patients of continuing long-term anticoagulation, and there is no increase of mortality in patients who have been continuing long-term coagulation. And the second parameter they had discussed was the intracerebral hemorrhage recurrence, which had occurred after starting anticoagulation. Most of the study had said that after starting anticoagulation, the ICH bleed had recurred. However, they weren't significant. They weren't significant enough to show that there was a significant occurrence of ICH bleed after starting anticoagulation after the patient who had occurred bleed. However, in case of thromboembolic complications, most studies favor that starting anticoagulation is better compared to not starting anticoagulation, favored by the I-square test and the p-value, which signifies that most of the studies significantly reduces the thromboembolic complications after starting anticoagulation. And the study also had compared whether starting anticoagulation or whether antiplatelet therapy can be replaced in place of anticoagulation therapy in these patients. So they also compare the same mortality, ICH recurrence, and TE complications. So in the mortality, initially based on 6 studies, they had compared whether restarting anticoagulation versus non-restarting anticoagulation. In terms of mortality, restarting anticoagulation is better than not restarting anticoagulation. And in comparison to antiplatelet therapy, based on 2 studies, they had said that they had favored starting antiplatelet therapy not than starting anything. However, there was a large confidence interval indicating that like it has its disadvantages. However, in comparison to starting anticoagulation therapy with the antiplatelet therapy, anticoagulation has been found to be preventing long-term mortality compared to antiplatelet therapy. In case of ICH recurrence, antiplatelet therapy shows reduced recurrence of intracranial bleed compared to the anticoagulant therapy. However, the confidence interval is quite wide, like for its recommendation to be allowed. And in case of TE complications, anticoagulation therapy definitely had shown reduced incidence of TE thromboembolic complications compared to antiplatelet therapy, which had shown, which had known to have, which had shown to have both side, like it had not favored towards one side for starting on anticoagulation therapy. So the system, based on the systemic review, we can assume that it said that anticoagulation therapy reduced the risk of thromboembolic events without significantly increasing the risk of ICH recurrence or long-term mortality. So, and the timing for starting the anticoagulation therapy after a bleed. So, they haven't given any clear clear guidelines on what time to start. However, there was one study done by Majid et al. Which had shown that and receiving anticoagulation therapy between 10 to 30 weeks after anticoagulation in a patient in a study of 177 ICH survivors with different anticoagulation indication. And there was the largest report from Sweden, which was done by Nyhan et al., which had shown that optimal time was 7 to 8 weeks after ICH bleed in 2,619 patients in survivors of AO. However, the American Heart Guidelines suggest that a patient who has developed a valvular heart disease, who has not on a prosthetic valve, suggests a 4-week delay after developing ICH bleed to start on anticoagulation therapy. However, in case of a prosthetic valve, one survey had said that it's preferable to start on anticoagulation therapy after 2 weeks after the development of ICH bleed. So, however, using antiplatelet therapy has been shown to be inferior in preventing thromboembolic complications. Evidences show that Novax is safer than vitamin K warfarin in patients with the AF, but unfavorable reports have been reported in patients with prosthetic heart valves. This was another study which was done after this.
I'm sorry, I'm going to be having to request you to finish in a minute.
This was another study which had done, which has similarly evaluated the same. So this was the largest study after the Nanish et al. Study, which included 2007. This study included 4,964 patients. It was a retrospective study done in Korea, which had shown similar things, such that using anticoagulation and antiplatelet therapy has significantly included severe thrombotic and severe hemorrhagic complications than not using any antithrombotic therapy. This image depicts the same. So, anticoagulation after 6 to 8 weeks in these people in this study, they have used anticoagulation 6 to 8 weeks after ICH bleed, which reduce all-cause mortality in these patients. And in this study they have said that there was no difference between the use of anticoagulation and antiplatelet therapy. And there was another study in which had helped us to predict which patients are more likely to develop the recurrent ICH after starting an anticoagulation. In this study, it had been shown that deep ICH bleeds are less likely to have recurrent intracranial hemorrhage can compare to low bar bleeds, and a patient with a large area bleeds have more chances to recover, more chances of causing ICH bleeds compared to the rest of the population. And though the risk factors which cannot be controlled, we can control the modified risk factors such as alcohol, tobacco, anemia, hepatic disease, by which we can reduce the incidence of recurrent ICH or thromboembolism. And these were the scores which have helped in assessing the risks of patients who are more likely to develop thromboembolism. And these are the scores like Hasbleed, Morbi, hemorrhage score. This helps in assessing the risk of rebleed in patients who have developed anticoagulation. So, summarizing, so the opinion for restarting anticoagulation varied between 3 to 30 weeks. However, multiple studies, there is no clear study to define which time to be started on. However, the largest Danish study said that 2 to 10 weeks, it's better to 2 to 10 weeks is the time better to start anticoagulation after ICH bleed. CT or MRI brain can be done before starting the ICH bleed to confirm the resolution of the bleed. In our patient, we had started anticoagulation over a period of 2 weeks. The patient has been planned for follow-up in OPD basis.
Any quick comments or questions? Rohit, I have a problem with your discussion and this thing. What proportion of patients in your meta-analysis and the recent large cohort that you described were patients who had mechanical valves or prosthetic valves? Unless we know that, and unless I know the details for that subgroup, this whatever you have discussed is irrelevant for this patient. because you are risking a possible valve dysfunction and even death because of a stuck valve if you're not going to resume anticoagulation on this patient. So there is no doubt that this patient needs anticoagulation. All your discussion about whether to resume or not, what is the risk of bleed versus this thing does not appear in this patient. Here you're not worried about thromboembolic events. You're worried about a dysfunctional valve, right? So maybe there is no data available on that, but whatever you have said does not make much of a difference to the management of this patient. You're going to resume. It's just about the time. If there are no further questions, I have a surprise for you.
Even for prostate.